10 or 15 years ago, we never would have thought this was possible.
A paradigm shift, which this is, changes eventually the standards of care.
We are going to treat the sickest of the sick, those that can't have heart surgery, where there really is no other option.
The aortic valve regulates the flow of blood from the heart into your body. Aortic stenosis occurs when the leaves of the valve get thicker and prevent it from opening and closing fully. This obstructs blood flow from your heart to the rest of your body. Your heart can make up for aortic stenosis for a long time, but eventually it won't be able to maintain the extra effort of pumping blood through the narrowed valve.
When that happens, people can have symptoms of either shortness of breath, because the fluid is backing up to the lungs and you can feel like you're almost drowning. You can have chest discomfort because of the stress on the heart muscle from having that narrow valve.
About 1.5 million people in the United States are living with aortic stenosis. When they start to suffer symptoms of advanced disease, doctors want to replace the valve, which until now has been done through open heart surgery. However, doctors are reluctant to perform the surgery on some of these patients because the risks are simply too high.
Typically, these patients are somewhere between 80 and 95 years of age. They have mobility problems. They have frailty problems. They have lung issues. They may have had multiple surgeries for cardiac disease.
Patients that have this kind of disease of their aortic valves really can't tolerate the invasive nature of surgery.
The traditional approach for aortic valve surgery is through an incision in the chest bone, either large or small, so that the patient can be attached to the heart-lung machine, the heart stopped, and then the aortic valve removed and replaced with either a mechanical or a tissue valve.
This new procedure requires a large, cohesive team of cardiologists, vascular and cardiac surgeons, radiologists, anesthesiologists, nurses, and other support staff. They all work together to replace the aortic valves of patients who are considered inoperable. This less invasive technique relies on image-guided technology. Doctors begin by inserting a catheter into the femoral artery near the groin, which provides access to the heart. Then, the artificial valve is crimped down to the diameter of a pencil, inserted into the catheter, and slowly fed through the artery and into the heart. A combination of X-ray imaging and echocardiography allows the doctors to see the progress of the new valve as it travels to the heart. Once it's in the proper position, just inside the diseased valve, doctors inflate a tiny balloon. This opens the new valve, embedding it into place, and it begins to work immediately.
There is a slight increase in the risk of stroke from this procedure compared to surgery. We choose the technology that's best for every individual patient. It may not be this device.
Their quality of life is improved for at least 2 years. We just don't have a lot of data after 2 years.
About 80% of patients are really fully functional again after the procedure, where before they might be on the deathbed.
It's been shown, at least in the Partners trial that recently came out, that TAVI is as good as the surgical approach, if not slightly better.
Leslie White, University of Rochester Medical Center.